Hi, this is Amr Hosseini, and I'm going to talk to you today about an interesting study that was published today in the New England Journal of Medicine about use of SGLT2 inhibitors, that dapagliflozin, in patients with CKD. As we know that the SGLT2 inhibitors has showed significant benefit with efficacy and safety profile in diabetic patients and also in patients with congestive heart failure. 2 weeks ago, there was a very nice New England Journal of Medicine trial published called also DABA heart failure, and it showed that the DABA was, significantly able to reduce the primary and secondary composite endpoints in patients with congestive heart failure with and without diabetes. Also, this study is very interesting, the one that was published today in New England Journal of Medicine, because also it showed the safety and efficacy of use of DABA in patients with CKD, even if they are not diabetic. This study is funded by AstraZeneca. I just need to say that I don't get any fund or money from AstraZeneca or other pharmaceutical companies. I'm part of several randomized clinical trial, multi-center trial, but none of them are related to diabetes or to the pharmaceutical agents using, the SGLT2 inhibitor. So this is the study that was published today, and as you see here, the date is 24 of September 2020, and they used a very good number of patients, more than 4,000 patients. All of them had chronic kidney disease, stage 2, 3, and 4, with GFR ranging between 25 to 75 per minute per 1.73 meters square surface area, and all of them, they have proteinuria ranging from 200 to 5,000. So some of the patients actually have nephrotic range proteinuria. The primary outcome was a composite of sustained decline of eGFR, at least 50% reduction of GFR, or end-stage kidney disease or death from renal or cardiovascular causes. Here is the study design. So the inclusion criteria, all were adults above 18 years of age with GFR between 25 to 75 and proteinuria as we discussed, and they have a stable kidney function on ACE or ARBs for at least 4 weeks. The exclusion criteria, they excluded for some reason all type 1 diabetics. I don't know exactly why. And they also excluded patients with polycystic kidney disease, lupus nephritis, ANCA-associated nephritis, and any patient who are getting immunosuppressive medication in the last 6 months prior to the study. They pre-screen the patients for 2 weeks, then they random the patient either to the DABA 10 milligram once daily or to the placebo. So it was double-blinded placebo-controlled study, and they followed them up, and actually the study was terminated early because of the efficacy and the safety of the DABA in the CKD patients. It is intention to treat study, so they calculated the power of the study to attain 90% power to detect 22% reduction in the primary composite endpoint. They need to have at least 681 events. Here is the demographic and the clinical characteristics of the participants. The age was around 61 in both groups, in the placebo controlled group and the DABA group. The majority were men, and the race, the majority were white. Also, majority were obese with the BMI around 29. Smokers, just a small percentage of the patient had smoking history. Blood pressure was well controlled in most of patients in this study. And the eGFR, the mean GFR was 43 in both groups. And here you can see the distribution of the GFR among the two groups. So very important to mention that they have about 14% of their participant with eGFR less than 30. This is the first study, to my knowledge, that they use the SGLT2 inhibitors with GFR less than 30. And here is other parameters. So, patient with nephrotic range of proteinuria, they have about 10% of patients with more than 1 gram of protein. About 50% actually had more than 1 gram of protein. So the majority have a significant degree of proteinuria. Very important, diabetics, only 67%. So 2/3 of the patients had diabetes. 1/3, as they are not diabetic. You remember that more than 4,000 participants. So if 1/3 of those participants are non-diabetic, only patient with CKD for other reasons, this means that they have more than 1,000 CKD non-diabetic patients in this study. Cardiovascular disease, about 1/3 of participants had a history of cardiovascular disease, 10% had congestive heart failure, and majority of the patients were receiving either ACE or ARBs, mainly ARBs. Here is a fascinating result. You can see the primary composite outcome, which include at least 50% reduction of GFR or need for dialysis, or death because of renal or cardiovascular cause, was significantly lower in the DAPA group. The renal specific outcome was significantly lower. Also, the death because of cardiovascular reason or any cause of death was significantly lower in the DAPA treated group. And here is most importantly is subgroup analysis, and I'm more interesting here comparing diabetic to non-diabetic. I thought in the beginning diabetics will have more benefit, but actually you see non-diabetics, the hazard ratio for decrease the primary endpoint in non-diabetic and CKD patient without diabetes, very significant, 50%. Wow, that's very good to know. So it seems that we now have an evidence that we can use the SGLT2 inhibitors, not only for diabetics, but also for CKD patients without history of diabetes. Of interest also, the kidney function. Patients with GFR less than 45, they have relatively decreased the efficacy. So I think it's important to note that it might be a good idea to use these agents early in the CKD rather than late. The degree of proteinuria for patients who had more than 1 gram of protein leak in your urine, the response was little bit less. And the patient who had the systolic blood pressure was less than 130, they have very good impact. So it seems that we need to use it maybe earlier in CKD with less proteinuria and with better control of blood pressure. I think these are the subgroup of patients who can get the most benefits. Also for interest here is the Black population. The hazard ratio for the Black population, 67% reduction of the primary endpoint in Black population. Here is the GFR. So for interest, for the whole entire period of the study. So as you see here in the DAPA group, there was initial dip of the GFR, possibly because of the decrease of the glomerular filtration rate, because of the decrease of intraglomerular pressure and tension. But this effect on the long term, you see that the kidney function was much better in the DAPA group compared to the placebo group. So here is a summary of the primary endpoint. As you can see, the primary composite endpoints that include the 50% reduction of GFR or end-stage kidney disease or death because of cardiovascular or renal cause was significantly lower. You see here 39% reduction. And here's a confidence interval. It's, the range is very narrow. This means that it's very precise. And as you see here, the end-stage kidney disease, the GFR more than 50% reduction was all significantly lower in the DABA treated group. Here is a secondary endpoint also. Here is, you see a significant difference between the patient who received DABA compared to the placebo group. So lower risk of kidney failure and all-cause mortality. So it's very effective. What about safety? Here is a comparison between the safety profile between the two groups, so that discontinuation for any reason or for adverse events were very similar. And also the adverse events in general in both groups were very similar. You remember 10 years ago when we started to hear about the SGLT2 inhibitor, there was a concern about amputation. I think this concern is vanishing now. More and more study showing that it doesn't increase the incidence of the peripheral vascular disease or the amputation. Zero ketoacidosis. Fracture rate is a little bit higher. I would be interested to study that and see what is the effect of the SGLT2 inhibitors on the bone health. Renal-related adverse outcome was very similar. Hypoglycemia was actually much less in the DABA group, and volume depletion was relatively higher. So I think we need to ask the patient and discuss with the patient that because of the glucosuria and increased diuresis, the patient has to drink enough amount of fluids. So to conclude here, it looks like the DABA and the SGLT2 inhibitors, we can start to use them in CKD patients without history of diabetes. The underlying mechanism is not completely understood. But however, there is many, proposals that the benefit of this agent is not only depends on the glucose lowering effect, but also because of the natriuresis. You remember, this is not only working on increasing the glucose excretion in the urine, but also the salt excretion. So this agent has natriuresis effect, and actually this is one of the major reasons that we use it now in patients with congestive heart failure. And also because it causes glucose-induced osmotic diuresis. So it improves the serum sodium, it improves the volume, and this is actually the concern that the patient might have some degree of hypovolemia. So we have to be careful when it comes to fluid management of patients on SGLT2 inhibitors. But it reduces the interglomerular pressure. So initially, same like ACE or ARBs, initially you see that serum creatinine might go up to 10, 20, maximum 30% increase of serum creatinine is acceptable. But if the serum creatinine is more than 30% or the GFR is less than 30% compared to the baseline, this is a concern. But as you see, safety and efficacy based on this study and other study, every couple months now, we are having more and more studies just confirming and assuring us that the use of the SGLT2 inhibitors in diabetics and now in non-diabetic patients with CKD and patients with congestive heart failure is safe and effective. I think the question now, when we need to use that, for what patient, and is it better to use it early or late, what degree of kidney function, what patient population? I think starting to use this agent and getting ourselves familiarized with this agent and their side effects and safety profile is going to tell us more and more about this medication. I really thank you for listening. And if you have any question, please feel free to contact me. My email address is amr.elhosseini.mo@uky.edu. And thank you for your attention.